Everyone wave. Okay. So I'm Andy Tennis. I'm your coworker. I am talking about reducing alarm fatigue. It is a problem that we have. I think down here is alarms all the time. So nurses work their entire shift listening to alarms. This encourages the noise to become white noise, kind of that overall you're hearing noise all the time. It makes us desensitize the alarms. We're not getting up as fast as we should. As well as you guys, I'm sure, are finishing the task you're doing before you're getting up to look at the alarm. Population we're going to be talking about is ICU patients and then emergency room patients. Okay, so factors that lead to alarm fatigue is poor EKG electrode placement. The alarm parameters are set too sensitively. We're not correctly trained on sensitizing those alarms, and alarm malfunctions. So some current data I found was a children's hospital in the US reported over 5,000 alarms in one day. 95% of those alarms were false. And then from 2005 to 2008, the FDA reported 560 alarm-related deaths in the US. So patient outcomes, what could happen to a patient because of alarm fatigue? Missed actionable alarms, patient death, and then increased patient falls. So I have 5 studies that I did. They're all based in ICU population. It's hard to find one in ER, but I think that we could take that data and kind of move it over. So the first study we did was testing physiologic monitor alarm customization software to reduce alarm rates and improve nurses' experience. So the purpose was to examine effectiveness and acceptance of physiological monitor software to support customization of alarms. The intervention was to customize alarm systems for each patient. So this is based on their EHR, their history, different patients you have, kind of what you know. The setting was in an ICU. The data they did was the number of alarms per day, and then they counted them pre and post intervention. So the GCS was worse during the implementation phase, but less time was spent on non-actionable alarms. And there was less disruption of workflow. The second one was skin preparation and electrode replacement to reduce alarm fatigue. So the purpose was to reduce the number of alarms that do not need action. The intervention was to wash the patient's chest with soap and water before applying the electrodes. Data was collected by counting alarms during an 8-hour period. This was also in an ICU. The intervention group had less alarms per day. So because they had less alarms per day, we can assume that alarm fatigue was less. The third one was an evidence-based initiative to reduce alarm fatigue. This was in a burn-intensive unit. So the purpose was to decrease the risk of alarm fatigue. The intervention was, they provided education in a series of steps. They customized alarm parameters, provided education on placement and daily changes. They used physical reminders, and they constantly shared that alarm data. So they collected data via statistics every 6 months for 4 weeks at a time. They collected data after each education model had been given. The results were significantly reduced number of alarms per day. So again, we can assume that because the alarms are less, alarm fatigue is less. The fourth one, the purpose was to assess nurses' perceived workload. So not necessarily the alarm fatigue, but how much work are we under. They viewed the relationship between perceived workload, alarm response rate, and care provider experience. So the intervention was a clinical simulator in which participants responded to alarms. So they had 2 different groups that were under 2 different settings. And participants were randomly assigned to those 2 different settings. Workload index was higher for the default alarms than it was for the sensitized alarms. Okay, and then the last one. The purpose was to reduce alarm fatigue in nurses. They did it in a bundle. CEASE is what it was called. They communication electrodes, so daily changes, appropriateness for the patient, set up alarm parameters, and education. They compared data before this and then after, and the total number of monitors decreased 30% after these were given. So, in the emergency department setting, how does a protocol to decrease the number of alarms compared to no protocol affect nurse fatigue? So, like I said, the population is emergency room nurses and patients, I think, because they're also hearing our alarms. The interventions that we should be doing is providing proper skin cleaning and placement, along with shaving the patients, and then individualization of alarm parameters. So we would compare prior to EKG cleaning we would compare data prior to the EKG cleaning intervention and alarm parameter customization to after the interventions were performed. So that's how we would gauge if this is working. So the outcomes expected would be decreased alarm fatigue, and I think we could tie it into decreased patient falls because that is measurable down here. So how we would measure it will be nurses will be interviewed on alarm fatigue before interventions are in place. So each of us would be interviewed. Then we would be interviewed after the interventions to see, how we're working, how the alarm fatigue is going, and then a T-test would be performed. So I have some questions that you guys have to kind of answer with me. So, is the intervention appropriate and capable? Are we capable of doing the intervention?
Yeah.
In the ER? Yeah. I don't think it would take extra.
We have the stuff, we just don't always take the time to do it.
Yeah, I don't think it would take a lot of.
Yeah,
Like
we try to make it work
Or even
instead of
cleaning,
like,
we just don't, we
Yeah.
just slap stuff on.
Yeah. And I made the point that sometimes it's impossible because we are emergency nurses and in an emergency you don't have time to do that, but a lot of the time we do have time to clean the chest and shave. So, how will the intervention positively impact the nurse's obligation to provide holistic, culturally sensitive, and patient-centered care?
Well, we would be less angry in our alarm fatigue.
Yes. I
And
also
so therefore, we would be more sensitive to their
needs.
we'd be more empathetic.
And I also think too, like, they get tired of the beeping, and then when we go in there, if we don't come soon enough, they call and they're like, hey, my alarm is beeping, and like the individualizing the alarms would probably let them know, okay, like we did something specific for this patient. They're not beeping constantly, wondering why they're beeping.
They're not as anxious.
Yes.
So a lot of the studies I looked at, the sensitizing the alarms are based on the patient's EHR, but because we're the first step in the door, they're not having that EHR. We don't know exactly how to customize their alarms directly. The legal and ethical implications for nurses who will be implementing the intervention. So what legal and ethical
I
things
mean,
do you have to
you're
worry
keeping your
about?
patients more safe, so hopefully less falls, less like adverse, effects and patient safety
That
events.
could come back on you.
So how implementing the intervention will positively impact the interprofessional team, so not just us, but the other teams that come down here. And I said that we're gonna be in better moods if we're not oversensitized or
Stimulated.
overstimulated, from those. We're just being nicer to them. I think that our phone calls will be a lot better because we're not listening to dinging while we're trying to give report.
And we're not sidetracked.
And too, like if you have like an ER tech who may not understand why a monitor's dinging all the time, or some other like PT, OT, whatever it may be, like if they're like sensitive to that patient, then you might not have that tech or that other person that's like, oh, they're dinging, I don't know what's going on, and so.
Or them not. Telling them when it's being something.
Your workplace's process for implementing the intervention. So we have an evidence-based practice council that this could be brought to. And then also our unit-based council, this could be brought to. I think a lot of education can be given. I also think that during our competencies, we could be providing education on this. giving those statistics, because I think that it's not something we always think about, and it's something that we probably should. I also looked at our policies, and they're awful. We have 3 minutes to get to an alarm. 3 minutes. I think if your blood pressure is 60, you have 3 minutes to get to it. That's not safe. I didn't think that was really cool.
Does it say like all alarms, or are they talking?
To medium alarms. It's 3
Like when they're
minutes.
yellow.
Yeah.
Red is like when it's like
Red, you have to go medium.
Yeah.
It would be VTAC,
But-
like our VTAC.
Yeah, but I mean, a low blood pressure will ding medium, will ding
Mhm.
yellow, and I don't know. I don't think that's right.
Or somebody sitting there at 80% for 3 minutes, that's a long time to, I mean, besides,
Yeah.
pre-COVID,
Mm-hmm.
that would be crazy. Now COVID, our patients are a little bit different, but
We're
pre-COVID.
sensitized to the,
Yes.
to the 80% stat.
Yeah.
we see it and we're like, okay, well they're 89, it'll be fine. Just
Yeah.
They're
yeah,
breathing.
yeah.
Yeah. So some other things I saw were, well, they're automatically set. We already have some parameters, but those could be better set by us. Alarm signals will not be set to such extremes that a change in patient condition will not be detected. We know that. And then 3 minutes. And then there's also another policy on the audibility, so just being able to hear it. And if we change the volume on that, it gets reported to the Fire Safety and Disaster Committee. So I didn't know that. So some barriers we would have to implementing the intervention. Like I said, emergency cases. I also think that, I mean, it's not very common you would see it here, but like privacy, people not wanting it, because we kind of just pull it down and
I've
go
had
to
people
town.
that they don't want their gowns brought down because they're transgender or something.
Uh-huh.
They don't want you to see their chest.
Yeah. And then if they have any allergies to the soaps we're using. And when we shave them, it's so patchy.
The men are very funny about you shaving their chest
Mhm.
hair, especially when you're making a smiley face.
Yes.
Yeah. And then who can advocate to involve implementation of this?
Everyone.
Yeah.
All of us, I think that we
Patient
work
techs
together.
And the
Yeah.
staff all put them on.
I think we can be reminding each other a lot.
Yeah.
So, all right.
Yay!